I'll turn it over to you, Rob.
Hey, Chris, thank you so much. Very kind introduction. Thumbs up if people can hear me okay? Good, great. So there were so many ways I could have come at this engagement today, and I pursued a particular way, but absolutely ask questions, push me in other directions, talking about equity, talking about health systems, talking about how to combine them, is a pretty expansive set of possible topics. So I put together what I hope could stimulate some dialogue, and just stop me at any time. I'll try to pause in a couple places and ask for questions. Just speaking to that issue of social justice. So one of the things I didn't put in was sort of like how I particularly center myself in simple ways about social justice and like description of paradigms of equity, because they can get so divorced from actually creating the change we want to see in a learning system. So I anchored it in a learning system, but at any point, let's pause and just say, hey, what are the best readings? What are the opportunities for frameworks around social justice? And spend a little time there. So pursuing health equity through learning health systems, what I thought I would do is relatively simple, share practical experience and lessons learned here in pursuit of health equity, and specifically developing learning health systems around in three different ways. So like three different mini presentations, each of sort of rising levels of complexity, but a learning system specifically focused on some social risks, a learning system specifically around like solving a wicked health problem, and then ultimately saying no social risk, no one health problem exists in isolation. How do we see that whole system's approach with multiple big dots that we're trying to move and design for equity in that kind of a system? And then along the way, understanding a little bit about what are some enabling capabilities. And I went through your elements of what a learning system is. And first, I just want to give a shout out, at least up until a year or two ago, like learning healthcare systems and learning health systems were used interchangeably. I don't know if that's come up as a teaching point along the way. So kudos for you for actually calling it a learning health system, because I think that is part of the premise of getting outside bricks and mortar to create change. So again, applied to a specific social risk, a health problem, and then an array, and then a couple of the ways we've approached it. It's not like we figured this out here. We're making some headway, and a shout out to some of the children's folks, Cincinnati children's folks on the call today, who are also working on this in various ways and shapes. But welcome your reflection, and as Chris said, push me with tough questions too. I was going to share.
Rob,
please.
This is a group that loves to talk and loves to ask questions. So thank you for encouraging dialogue. And I'm going to ask you, just before you jump into the conceptual stuff, could you back up a little bit and talk about, and maybe this will be in there.
Yeah.
Is this a strategy of Cincinnati Children's Hospital? Is it a deliberate strategy that the board developed, or did sort of your work raise it, elevate it in terms of its visibility? How did that happen?
And I'll tell that story as I go, but the bottom line is like Children's Hospital did nothing with equity, in 1999, 2000. Jump forward 20 years, and we just spent 6 months with McKinsey developing our next 15-year plan, and community health and population health is like one of 4 pillars for the next 15 years. And our CEO and our board chair will say, like, we started as a children's hospital in 1880 or whatever it was. And so in 2033, when we're 150 years old, what do we want to say about the health of kids in the region? And so it's been a fast, relatively speaking, 2 decades. And it is interesting to ask why some hospitals are ready to commit to health equity, sort of population health equity, and others aren't. But I would say now our CEO and our board chair and enough of the board are committed to it that I don't think it's going away anytime soon. That doesn't mean we have figured out all the disincentives at a clinical level or all the academic disincentives to focusing in what's really a tough and messy space. Not easy to get grants, not easy to put clean papers out in this area, but I'd say the hospital's been pretty committed. And the way I was going to tell the story is a little bit is like, how did we build the confidence that we could get results? And I still remember in 2006 when I took, or 7, when I took my first QI course, and I was working on the program I'm about to share with you. The CFO was giving a talk, and he was like, Rob, stop trying to solve world hunger. That kind of a feel. And, we're talking about keeping kids with asthma out of the hospital. And he's like, wait, I don't have a business model yet to fill those beds. So that kind of constant tension, I wouldn't say is completely gone away, but definitely, pushback early on. No, he was funny, Scott Hamlin. I don't know, some of you may have known him, but he would also say, of course, they hired me as the bean counter, so that's my job to tell you that. Luckily, there's a board that keeps us doing the right thing. So you keep doing the right thing, but I'm going to keep asking the bean counter questions about your work.
If I can just interrupt for seconds, I tend to do it. When I was the chair of the Agency for Healthcare Research and Quality Advisory Council, they invited someone from the Secretary's office, Azar's office, and he was going on and on about improving health and healthcare, and he actually mentioned disparities, which I don't normally hear from those guys. When he was all done after 15 minutes, I said, and he showed the classic map of the states where health is absolutely abysmal and states where it's better. And as you know, a lot of the poor performing states are in the Deep South. And I simply asked him, I said, so when you're talking to the secretary, do you ever talk about structural and institutional racism in America and what you're going to do about it? And he literally said, we can't boil the ocean. And I said, okay, so from the point of view of HHS and this administration, it's basically hopeless. They don't talk about racism. They don't talk about policy. And he actually said, that's a policy issue before he said, can't boil the ocean. So I share your frustration with the tension. It's really hard to avoid despair when leaders of the country won't even talk about it.
Yeah, no, absolutely. And I was just on the phone with our division director, right? When Medicaid reimbursement rates don't let you do the right thing because they're so low, what can you do? So see this as this progression. The social risk is where I started. Taking on medical outcomes was where we went to next, and then so the last piece is more full embodiment of where the institution is in this work. And again, lots of things we didn't do along the way that we could have or should have, but hopefully with your questions, we can help illuminate like what about this is true learning health systems. My sense is the term can be a little bit loosely applied. I absolutely think these spaces are so fraught with failure, lack of evidence, opinion, that everything we've tried to do along the way has been like, how do we know we're getting better every day as part of it? So I'll just start here because I didn't know exactly how you all are framing learning health systems. This is a little bit of my condensation of it and how I would judge whether we're moving forward, especially as I present the latter segments of the work. But are we developing shared purpose? And this is better when it's animated in full screen, but I'll just lay it out here. Do we have rapid learning? Are we building people and capabilities along the way? And can we get to scale and sustainability? And I think to solve equity issues, we need, at the very least, all of this and more. And a lot of what we try to do as we've gone along the way is very consciously work on each of these. Spend time on the vision and on the design to get to shared purpose. Really push everyone when they say, well, we can't do that. Peter Margolis taught me to say, well, what could you do? What could you do tomorrow? That kind of classic, how could we learn when you think you can't possibly change your Head Start referral system or your eviction mechanisms? How do we bring some of what we've learned from industry and embodied in our hospital and help teach it in the community? And then, and this is the hardest part for us, and I think for many, is how do we think about full scale and in a sustainable way? So just pause here. I just want to reflect, this may not be how you guys have thought about learning systems. Anything here stand out as like wrong or key elements that you think are missing that aren't called out here? We don't have to spend a lot of time here, but I just wanted to sort of calibrate. If it doesn't seem completely wrong, then we can keep going, but I just want to make sure I wasn't way off track as I talked about the rest of it. Great. All right, well, let's keep going and come back to it along the way. So the first one was really where we started our journey in health equity. So I was first 2 years of faculty were at Boston Medical Center, and at the time, Barry Zuckerman and a team were really trying to figure out what can we do about the social determinants of health. And there was a emerging model of doctors and lawyers working together to help low-income families. And so what I'm sharing here was, a relatively early transformative sequence of events for us, and building, as Chris pointed out, to an increasing belief that, in fact, we can do something about equity. And so what you see there on the left is a letter and an issue that was eventually surfaced that resulted from a resident in the summer in Cincinnati asking a parent of a child with asthma, how's your child doing? Tell me what's going on. Is your housing okay? And the mother said, well, my landlord has told me if I put an air conditioning unit in my apartment, I'll be evicted. And again, eventually she produced this hanging from the lobby of the building. And we had set up a system where the residents were starting to routinely ask these questions and routinely refer to our legal aid counterparts in the practice. And within the course of about 2 weeks, our legal aid attorneys had a third case, all through different residents and doctors, a third case in which a landlord had threatened eviction for putting in an air conditioning unit. And what it eventually turned out is they asked that simple question, who owns these buildings? And like to this day, as like equity oriented as I am, it's just like not the question that rolls off my tongue. I need another partner that's their primary question, like who is the landlord, or who are the landlords that own this? And it turned out there was a single landlord, absentee, living in New York, who owned 18 large properties in Cincinnati. And you see a map there with the dots on it. It's a total of about 700 units for families across it. And we later learned it was like the second most distressed set of properties in HUD. But nothing was happening. This landlord was like going into foreclosure in New York, and the property manager wasn't doing any upkeep. In the end, working with legal aid, they took on a class action lawsuit. They worked with Fannie Mae. They worked with HUD, and eventually found a new buyer for the properties. But along the way, putting in millions of repairs. And that picture on the bottom right, are folks on the roof of that apartment complex, putting in a new roof. And that notion being, it would have been so easy to miss all this altogether and just double the flow vent, or get a school nurse to do the albuterol. But what was really hurting this kid and 700 units worth of kids was really toxic housing. Eventually led to a $30 million HUD grant to rehab, and they're finishing up the rehabs of all 18 buildings at this point, like real gut and rebuild. And this notion being like, how do we learn? Like my job is the clinical care around the asthma. Legal aid's job is stabilize the lives of low-income families, housing, jobs, domestic violence, immigration. But how do we learn how to work hand in glove so that we can actually improve health equity outcomes? And as we got deeper and deeper into it, relatively early on, we produced maps like this. So what you're looking at here is the city of Cincinnati and its neighborhoods, and from green to red is the rate of asthma admissions, and then the blue dots were, once we combined our data sets, we could map where are the housing cases that legal aid is experiencing and adjudicating property issues, and where are asthma rates, right? And you start to see the clustering of housing cases in the hot asthma areas. And we talk a lot in system science, like how do we get people seeing the same system? as opposed to I'm optimizing their lungs and they're optimizing their income flow or their payments to landlords. But actually, of course, the name is eluding me, Edward Tufte, right? Like once you put up a map or once you put up an image, people start to tell stories, and it's a lot easier to get to that shared purpose kind of thing where you're like, oh my God, how could we not be working together, right? Are the overlap of our populations and our deep, care and love for low-income kids and their families are so similar. How could we not begin to think about how to optimize it? So, obviously there were technical issues and privacy issues to how do we bring together the data sets? But I would say learning how to build that sense of shared purpose and opportunity to become more as if we were a single system, I think was aided by some of this, A, early stories, and then B, combining the data. You see on the right there, it's facilitated, and I think you've got stuff on informatics and other elements. Our system and our partnership was facilitated because early on we spent the time trying to not only just embed social determinant screening questions, but embed the EPIC order for a referral. So in fact, we got to the point where legal aid referrals, we called it Child Help or the Health Law Partnership, was second only to the speech and language referrals, like more referrals than to cardiology, pulmonary, and a far better follow-up rate, like 80% of all the kids referred, we now can track in the legal aid system, and we, as opposed to say our behavioral health referrals were about 15% or 17% have shown up within 3 months. So, building that shared vision, putting together a data infrastructure that let us track the kids, now leading to actually, and this is literally just from this past Friday, where together what you're looking at are SPC charts, and I can't remember if you guys get into statistical process control charts or not, but what you're looking at here on the left is our rate of referrals to our legal aid partners per 1,000 child visits from January 15 to August 2020, and annotated for various changes along the way. And I apologize, a little bit small. Let me see if I can just make it a teeny bit bigger. At some risk here to muck it around. No, it's not going to work easily, but basically, annotating so that, we sit down, once a month with lawyers and look for changes in the system. And, I'll just say, if you look at the upper right, not only can we tell what our rate is per 1,000, and we can tell it by clinic on the upper right, is specifically for the case referral. So this was for housing cases in which there are toxic housing conditions or threat of eviction. And what you see here is a sudden drop. And I don't know if can you see my cursor when I move it? Can't tell. Yeah, you can. And suddenly you have a bunch of lawyers saying, "Hey, what's going on there? Why is that happening?" As opposed to a typical referral program where it's case by case by case, and lawyers especially have typically gone by, on a case by case, and every case is different, to start to say, wow, this is our 3rd month in a row in which our housing referrals have dropped. And the annotation there is in the spirit of open access, we opened up the whole lot of open access appointments, which meant families not just for ill visits, but for well visits could just walk in. So it's not hard to begin to hypothesize what was a well-intentioned effort to give parents a lot of choices to when they came in, meant they ended their relationships in meaningful ways with the one doctor or person they trusted who could ask and follow up on these questions. There's a COVID-19 impact. We've talked about an eviction tidal wave coming. We're monitoring, we just talked about it this morning, right? You see a couple points outside of control limits there for housing-related cases. Similarly, on the education work and COVID, you see a drop. So I think, the point isn't per se about legal aid or about housing, but who are the right people? What are the outcomes? What's the system you're trying to change? Who are the stakeholders, and how do you act as if you're a single system, and then learn like heck every month, every week, every day as part of it. And we've gotten to the point where, yeah, please, yeah.
So this is really wonderful to look at over the 5-year time span.
Yeah.
You had turnover in your community partners, and how do you educate the parade in that context, right? Because I think that you're meeting weekly or monthly, but the people that you're working with could change. And so how do you,
that's a great question. And it sounds like you're someone who's probably experienced, like, I thought I had a great partnership and then that person left. So we have actually had very good continuity of leadership, and I'll use this to give a shout out to my legal aid partner, Elaine Fink, who's the managing attorney for Children's Issues. She's been a constant, but we absolutely have had folks turning over, including in the clinical leadership side as well, which is almost just as important for buy-in. And so, really attending to how do you create an enduring program. And you can imagine the battles for sort of pre-clinic teaching. Like, no, we got to teach about incontinence and uresis today. Or like, no, we got an eviction tidal wave coming. We have to teach about that. So both training on both sides. I think, in that spirit of all teach, all learn and generosity, I have never missed an opportunity when the partner has called on me, hey, could you come down and give a talk on X? Could you bring that clinical story to the team? Or could you join me on a fundraising salon? We're bringing in legal aid donors in the past, so that it's not dependent, it's a system, right? It's not dependent on, God, Rob is now good friends with Elaine Fink. Like, that's a terrible way to design a new system, but rather, what are our responsibilities? How do we encode that in our teachings, in our management meetings, and the data we're looking at? And I would just say, for some of the other work, if need be, how do we engage the board? So when the CEO of a big institution, whether it's United Way or child welfare, turns over, we know we have the board has an eye on this and is engaged. Great question. Other questions about this? So there's the last slide around, like, how do you go from, there's so many excellent and really well-intended programs, whether it's, it could be across anything, and build the learning system with the right stakeholders. So I'd be curious if any of you have a program or an initiative you've been doing, and how do you build a learning frame around it, because you feel like there's room for improvement. But thoughts on this or application to your own work that can be useful for? Anything about this missing, not make sense?
Well, let me call, is Erica on the line? Erica Sood?
I am, yes, but I was on mute.
Yeah, okay, great. So Erica, why don't you just introduce, tell Rob, in a couple of sentences what you do, and then how what he's doing in the community relates in A, B, and C ways to what you're doing with patients with cardiac conditions.
Yeah, so I'm designing an intervention to help to better support parents who receive a diagnosis of congenital heart disease prenatally. And I'm just in the process right now of developing that intervention. We partnered with parents, both as parent partners as well as participants through online crowdsourcing, to actually kind of have them help us to design the intervention. And then we also worked with them to have them actually help us to identify the outcomes that they felt were most important. And then now we're having them help us to identify the measures as well. So I mean, I wouldn't say we've done exactly, certainly nothing on this scale, but certainly, developing partnerships and has been very, very important. I will say, I think there's one thing that you brought up just about turnover that I think I've struggled with, not so much with this project, but with other projects. I do some, quality improvement work in the CICU, the Cardiac Intensive Care Unit. And I think it's been really challenging, when we do have champions and projects are going really well, because you have these, nurse champions, let's say, who are really gung-ho about the project and can kind of engage the whole community in this case, the CICU. And then they leave. And you're kind of, I've struggled with that. Like, how do we maintain projects in that setting? So I know, Chris, that's a little bit of a different issue than what you asked me to talk about. But that was something that just kind of stood out to me a little bit.
Yeah, I think, this initiative, even now we're 12 years old, doesn't have sustained parental involvement. So kudos to you for bringing parents into your cardiac work. And you'll see in the subsequent ones, we've spent a lot of time thinking about it, how to more deeply involve parents. I will say the storytelling of parents and the voice of parents here come through, because we committed early on for signature cases that the legal aid attorneys will email back to the doctor and CC key leadership about the outcome of the case, which builds this sort of flywheel. So then when that resident turns over or does his ER fellowship at Children's or somewhere else, they're bringing that, like, gosh, I can't believe I simply asked, like, are you doing okay making ends meet? And this family ended up with $400 more per month in SNAP benefits, and the mother cried. You know, that kind of emotional feel. But then to your second point, by CCing the right leadership, we're encoding it so that the next champion, we don't know who it might be, you know, but someone raises their hand and says, well, you know, or just even chimes in. Peter Margolis again taught me to listen, like who speaks up, who says, wow, what an incredible case, and try to recruit the next potential nurse leader, you know, as you're going. So no, great questions. I think the parent engagement piece, as I'll share, I do think is among the hardest things to do in our settings, to have sustained engagement. But whenever I've brought together community partners in a meeting, they'll say, you know, what felt really different about this meeting was parents were present. So keep going with that piece. I will say the other piece I'll just say is we have a new value-based care provider starting up here. And we had a kid in the cardiac intensive care unit whose mom was having a really hard time with housing problems. And this child will become a member of our new ACO. And legal aid stepped in, because they're also a patient of our primary care clinic, and stabilized, on its way to stabilizing the housing. And the mother was just so relieved, because it was one less thing to be worrying about when she has to bring this 2-month-old home. And so I made sure to send that case to the new director of our ACO, because someday I'd like to imagine that he's going to be paying for, you know, legal services in the same way we find a way to pay for social work services. So again, like using the stories, using just enough data to help nudge other pieces of the system to fall into place. So whether it's your patient services or your nursing leader, who make sure they hear about the partnership, so when your partner leaves, your champion leaves, she's ready or he's ready to replace that person with another one, building the case. All right, any other questions about this?
Did you you had mentioned a little bit about the difficulties with privacy with the data and being able to share with that. How did you kind of approach that in sort of a high level or sustain that?
Yeah, great question, and we come back to it because, you know, once we got past legal aid, it just gets even more and more of an issue. So, you know, early on, there were fears that they would be inside our health record system, or that they would use it to sue the hospital. You know, so we made sure the CEOs and our legal counsel and their legal counsel, you know, set the parameters of the kinds of cases that would happen. And eventually, like with a business associates agreement and others, setting up a unique identifier so that we can link who did we send and who did they receive, and that notion of you know, continuous management. It's been less of an issue here. You know, we haven't cracked the code yet with our public school district, right? So then they've got FERPA and we've got HIPAA. And when we get to, you know, we could share like how we're trying to build the use case. And basically, you know, while I love all our bioinformatics friends, you know, I'm to the point where once you're outside healthcare, you know, unless the use case is so compelling that people start to realize, that the resistors start to realize kids are being hurt if we don't start to link the data, it just becomes really hard, right? So so that's a bit of where we are headed in our education space. Like, who are the 5% of kids out of our 37,000 who frankly will get hurt if the school district doesn't know they're coming and doesn't know what their limits are, and isn't prepared? You know, how do we build that case for them to get beyond it? Yeah. All right, well, why don't we talk about sort of, that was on the social risk side, like it wasn't medical outcome driven, but share with you some of the work we did in preterm birth. And so what you're looking at here is from Vital Stats data, you know, early 3-year period, 2010 to 2012, across the 80+ neighborhoods of our county, and it's the preterm birth rate per 100 live births. And of course, you know, even at a distance, you don't have to see all the neighborhood names, but not surprising gradient in preterm birth across the neighborhoods. And I call out Avondale, and that's where the hospital sits, about 200 births per year. And and when you think about the vast efforts of NICHD and March of Dimes and others to crack the code on preventing preterm birth, and the incredible systems that have led a parent to get to that moment, and to me, it was an opportune space to think about how to apply a learning system to get better, since our search for all sorts of receptors wasn't working. Why not take a different approach and see what collectively we could do if we approached it in a system science kind of way. And so and we had a lot of help, Don from IHI, Tom Nolan, and others, sort of guiding lights for us in thinking about this work. But if you were to say, like, what are the components of a system just in the prenatal and early postnatal period that could be playing a role? You have mothers and kids, you have obstetric care, birth hospitals, pediatric care, community agencies, home visiting, really as a jumble of services. And the question is, could we get all elements? Could we define the system with parents and mothers at the center, and get to an idealized system in which everyone was contributing their best selves in a shared theory to get to an outcome? And the way this is drawn is with the mother and infant at the center, home visiting sort of wrapped around them, since the vast majority of the time the parents are not in obstetric care inside an exam room, but rather home visiting in its best way is developing trust and navigational capabilities and solving problems in real time for a parent. And so this is a time where we really spent 6 to 12 months up front saying, how are parents viewing the system around them and what they need for support? And I can't tell you, like, the back and forth with some of the partners as to whether this was time well spent or not. Like, don't we know what parents don't have and what mothers need? But really some powerful sessions. We worked actually with a professional nonprofit called the Business Innovation Factory out of Rhode Island, who really does this for a living, as opposed to, hey, I'm a qualitative researcher, what can I understand? Including developing personas and peer researchers and doing video interviews inside homes. But I just throw this up as an example. They came out with 4 key themes that should infuse the whole system. So it's not about this in particular, but just this idea that listening carefully, we could get some guiding principles of how we should be thinking about it, a system built differently. Future casting, that's like the ability, not surprisingly, to look into the future and make decisions now based on the future. Trusted knowledge, and I just remember the moments where I said, "Oh, I love Dr. Elizabeth. She's so amazing. I trust her." But Grandma said, like that notion of, like, how can we deal better with those ambiguities? And when we think we have a trusted relationship, but the wisdom is coming from outside the healthcare system, personal power and community love, and just sort of emphasizing the more complex the system we're in, the more, like, through whose eyes should we be doing the rebuild. And I can't remember among your competencies if some level of design thinking or person-centered redesign is part of what you guys are working on. Somebody remind me, Chris? Or...
Yeah, no, it's not. It's called out explicitly, so this is terrific.
Yeah, and again, happy to share some of the booklets they developed for us and potential prototypes. How might we achieve X? But part of it was, like, what is the system then, and its elements. So the goal was, for 205 births per year, how could we have a 10% reduction in prematurity? And again, apologies without the animation. This is a little busier than I wanted to be, but here are the 200 births. Here are their anchor institutions, the churches and places families gather. They enter the system. UC and Good Sam are the big prenatal care clinics, but there were a number of, on the Pareto, a number of outliers, the 2 big birth hospitals. Down here are the various home agencies that build trust in the home, right? It's kind of like the time to a trusted relationship to home visiting and community health workers and ministries. And then community agencies building, addressing basic needs. And we basically set metrics for each of these, right? So we tried to figure out who was critical, where there were things we knew what to do and we just weren't doing them, where the things we didn't know what to do and we should be prototyping, and then try to get everyone, including the two big competing OB centers, to agree to certain metrics. Can we get 90% of women in to prenatal care by 12 weeks? Can we get 90% enrolled in home visiting by 15 weeks? Can we get 90% referred for resources by 18 weeks? And of course, the huge fear-inducing things, and that's out of my control. If the OB doesn't send them to me in time, how am I supposed to make sure they're enrolled? But you can imagine the challenge and the huge importance of having parents in the room saying, this is what I need, right? You may have all these constraints, but this is what I need. Working through the stakeholder engagement to set up these, not just to have metrics, but they're not there to evaluate, but to learn. So how to get the data systems going so that, literally every 2 weeks, then what you're looking at here is for the two big prenatal clinics, what was the date, what was the gestational age at entry, and having learning times in which we'd say, hey, this woman came in at 5 or 6 weeks, like from Avondale. It's like the lowest income neighborhood in our area. What brought her in at 5 weeks compared to others that are coming in at 30 weeks? How do we learn from the outliers? How do we tell stories? How do we try different things and put this overall, into then run charts and plan PDSAs for this? Now we had the same kind of learning for home visiting. We got a couple of our home visiting agencies for each woman who enrolled. How would we learn it? But we just kept coming back to every month, were there any preterm or extreme preterm births? And what was the case story on them? When did that woman enroll in home visiting? When did that woman enroll in prenatal care? Over the course of 3 years, tried to, essentially build a better system to help women. Now, there's lots of stuff we did in the community, and we can get into that, but I want to make it sort of about the outcome. But this idea of how do you get competing partners who all said, I have a great program. We give the best prenatal care. We do the best home visiting. And yet you just say, well, that's great. I'm sure you give great care, but you still have a preterm birth rate of 18% or whatever it was at the start. So how is it we all give great care and we still have among the worst preterm birth rate and extreme preterm birth rates in the county? And creating a safe enough space for that daily learning and case stories as part of it. So before I share just a little bit more questions about the setup of this, like complex problem, so many people have a piece of the puzzle. There isn't real-time data. There's nobody holding up a candle at a population level for very low income and Black women. How are they doing? But coming to shared vision, sort of shared purpose, usable data, just usable enough to learn from, and a system to learn at least every 2 weeks, if not every week, what's going well and what's not, and then to hear from parents directly their experiences. So, questions?
I just have a question about whether or not the group stratified some of this data by different demographics. And one thing that we found in our substance exposed newborn work in our state is that we've all over time come to a better outcome and reduced length of stay, but there was significant disparities by race, ethnicity, and language in when that change happened. I'm just curious if that's something that this work has looked at, just knowing how profound the racial ethnic inequalities are in preterm birth.
No, so great question. So like part of our proposal was all about risk segmentation. And in the end, this is such a high minority, low income area. The risk segmentation within ended up not making sense. But I think your bottom line question is like, how do we illuminate what we're working on? Like, what are the questions in the back of everyone's head? How do you not get paralyzed by analysis, but look for illuminating things, hopefully up front and along the way, and be responsive to questions like that? I definitely think segmentation in general is a great way to go about it. Here, I do think, racism in the care of these women, who I think 90% are are Black in Avondale, 85%. Definitely a key piece, and a key piece of the trust problem, right? So on a Friday afternoon, I'm having a little bleeding and I'm scared. Who am I going to call? Like if I've been treated disrespectfully, we try, and I'll just say one of our big fails was we tried to directly address that issue. We created video, we did a lot of storytelling, and I'd say we didn't make a lot of progress in our anti-racism work. Again, this was 2014, 2015, but I think you're thinking along the right ways, right? In particular, how are Black women doing, white women, Latinx women as part of it. Other thoughts or questions about the setup of this? I sometimes like to say, if Jeff Bezos was trying to deliver health to Avondale, or if he was trying to stop extreme preterm birth, what would he do? And, he wouldn't say, each of you, warehouses, just do your best, and I'll hire a lot of care managers in between you, and let's not be so customer centric, but rather he would say, like, how would you put it together? How could you be the most customer centric system, and eliminate all the unnecessary transactional costs and friction? So this is where.
One more question.
Yeah, please.
Just thinking about these competing healthcare systems, how easy or not easy was it for them to share data around these metrics?
Great question. We in the further progression of it, as we built sort of more of a learning collaborative across 18 or 20 health centers, we finally got sort of an informatics platform in which folks could load it. I would say, luckily, the two lead OBs, one from each of them, had a pre-existing trusted relationship with each other. And we were able to share data in this, certainly in this way. And then when we got into a little more like case studies, where it started to get a little more what happened, we had a 26-weeker, there was this sense of collective loss that wasn't just a fear for me. As we started to get results, we got to the point where there was like this days between chart between extreme preterm births, and collectively the whole system was sort of like, no, let's not reset to zero. So there was this urgency, like, hey, did that community health worker make a difference? How could it have gone better as part of it? I would say it probably helps that these were women mostly on Medicaid or uninsured. So the intense market pressure, had this been like transplant or something, my guess is would have been harder. So this is
one question.
Yeah, please.
Rob, you alluded to the parent engagement. Would you say that you used like a mixed approach where, because I know that these families might be the hardest to touch or connect with. Would you say you used the home visitors to connect, or were they actually part of the team, or kind of a mixture of both?
I would say a mixture of both. In that, absolutely, we relied on community health workers and home visitors to build trusted relationships, and probably even more so than actually coming in for an appointment. But we also wanted them on the team to the best we could. And so, as a prelude for that, one of the prototypes that we started at the beginning, that's still going on now, 7-8 years later, is breaking bread together. So we actually had a meal. We have a meal once a month at one of those churches, in which the goal was like, it's not about like teaching. We would come and eat, they would come and eat. There'd be icebreakers. If a particular OB case manager or community health worker had a family in the neighborhood they wanted to bring, be in that space together as a prelude to them then getting comfortable saying, here's what didn't go well with my doctor, or here's what I love about my doctor. He rounded on me even though he wasn't supposed to be the rounding doctor on call, that kind of thing. And then you feed that back to the doctors. And what we realized is those meals were more, not in retrospect, not surprisingly, far more about changing us than changing the families in in a new way. I think we're getting to the point where we have a health system that's ready to listen in a systematic way to what the parents suggest. Anita, I think you probably know some of our other work with All Children Thrive, in which they're giving keynote addresses, and they're doing poster reviews with us, like side by side, including going up to teachers and saying, that program doesn't work, for my kid. What else could you do? At this stage, I think we weren't quite in the full improvement team, full co-production kind of mode. Other questions? I'll just share. So again, like you're used to like infant mortality being a year or two behind, or preterm birth, like, well, that's the domain of vital stats. What we ended up being able to create was, a system so that every month we could say, there should have been roughly 17 births. What's the preterm birth rate? And this is the extreme preterm birth rate, so less than 18 weeks, less than 28 weeks, sorry, by quarter. And again, obviously, it's going to bounce around a lot. There are about 40 to 50 births per quarter, and there was always typically 1 to 2 extreme preterm births, which is 60 to 65% of infant mortality is driven by the extreme preterm births. And so here's our baseline from 2009 to 2013, and we launched, and it took probably 9 to 12 months to get our act together and to start engaging women whose pregnancies are going to then be another 7 to 9 months, and really then having 3 years without a single extreme preterm birth in that neighborhood. And then I just included a couple comparison neighborhoods as part of it, so it was not massive gentrification or a shift. These are demographically comparable neighborhoods. So I can't easily say that it's 100% due to this particular effort, but I can tell you that like literally every morning we had nurse case managers waking up and saying, I have 72 women from 45229 zip code or from Avondale, and I know where each of them are, what each of them needs. And by the third year, I mentioned the legal aid. We had actually brought the legal aid program into the OB space, so that within 12 hours or 24 hours, if a mother was hungry or threatened with eviction or anything like that, legal aid was solving their problems. So again, this is one example of a complex medical problem, but if you generalize it and say, long-standing problem, hasn't been cracked, many stakeholders, how can we bring them together? How do we use parent voice or patient voice to help guide what a better system would look like? And I see, mothers who say my eviction date is the same as my due date. I don't know what to do. Like, how can you not do better than, at best, a social worker coming in and saying, here's a phone number for Metro Housing, but really instead now I've got a paralegal on my side or an attorney on my side, and my doctor knows the community health worker, and the community health worker knows my doctor. Like all sorts of stuff like that. I think are part and parcel of this. Just as again, I try. My mentor told me never declare victory in infant mortality, because many places have tried. I'll just share this as at least during that time period. This was Avondale's infant mortality rate in the prior, and this was Avondale's infant mortality rate over the course of the successful piece of the grant. So I won't get into like the challenge of scale and handing this all off to another organization to try to go to 5 or 7 zip codes. It's obviously another order of magnitude of challenge, but let's just pause here, even go back to here, and questions then about complex medical problems with many stakeholders and bringing them together into a learning system in which everybody trusts each other enough to say, what can we learn today? Thoughts or questions about this?
I have a question for you, Rob.
Yeah.
I've seen some of this work presented before, and I'm always just really impressed when I look at just the scale of somebody had the idea like, oh, we can work on this and figure it out. Because my first reaction when I hear these problems is like, this is way too hard. Like, it's hard just being a subspecialist worrying about these 3 things that I take care of, let alone these systemic issues. Who are the sorts of people and what are the skills that they bring to these large problems that really can unite people together? Like, is it like, as a physician, does that give you a certain platform that is respected better? Is it getting politicians? Like, who are the people that you feel like you need to make these conversations happen in a productive way?
Yeah. So, these would just be my take on it. And from my experience, I think physicians are incredibly well positioned to set the vision for this. And I think what we often struggle with is setting a vision, like getting to the how might we, and is this really unsolvable? And I can't remember which kinds of kids you see in clinic, but what I found is if someone sets the vision, inevitably people get charged up. Because there's always, everywhere I've turned, there's always this cadre of people who have wanted to make a difference but have been struggling in their own space. And so by lifting it up to like 1 or 2 levels, suddenly school nurses realize they can be part of a solution. Or, right, we've all seen the world of pharmacy change. These community pharmacists who, like, I used to work at a pharmacy as a delivery boy, and it was like the town pharmacy and everybody knew everybody, to like, you go into CVS and they're just churning. But that opportunity to set a vision and find a couple pharmacists, a couple school nurses, a couple home visitors, a couple community health workers, and say, what could we do? The last 3 patients I've seen had X. So I think like how the equity issues get written into the body, it's very powerful then for a physician to say, here are the implications of their unstable housing or the lack of food, or that they live in a pharmacy desert, or that they're at school and nobody's there in the morning to give them their medicine. So the physicians play a role. I think, in the end, we've had some powerful nurse leaders along the way. Absolutely. We have powerful parents. I mean, it's all part of this sort of distributed leadership that it's not just the physicians, but I do think when it comes to equity, there's this classic quote from Rudolf Virchow, right? That physicians are the natural attorneys for the poor. If you've ever not ever read Rudolf Virchow and sort of social pediatrics, it's worth going back and taking a look. But I'd welcome, your experiences, what you've seen set that vision, and they have to have enough power to take some risks. So I think that's part of it. Is it's one thing to set the vision, but then how do you set yourself up in your academic careers or wherever you are to be allowed to take some risks, finding a funder, finding a division chief, finding a board champion who says, this is really important and our job is to do the right thing. So I can help you. But others' experiences in this area?
Rob, can you I just wanted, you go, who was that? You go first.
Oh, yes. No, I feel like there's a lot of practice that I can't underestimate when it comes to doing the elevator pitch. And like, even with people that aren't in the decision-making level, at least at my stage of still trying to figure out what is my leadership style and all these things, the more I can talk to people and crystallize some ideas, even if it's like a flail, it helps to, when I am ready in that moment to have that elevator pitch with someone who can make a decision, then it starts to snowball. Yeah.
And classically, right, some people love the stories, some people love data, some people need both. I think never underestimating the need for having both in hand, just enough data so that your story is backed up, but then don't forget the story as well as part of it. Chris, you had something?
Yeah, I just really appreciate one of the last things you just said, which is the importance, if you're based in a healthcare organization, to get alignment from the ground level where you were all the way up to the board on these initiatives. And I wonder if you could just talk a little bit about that, because there's a chicken and egg thing here. It sounds like, if I'm reading what's going on, what happened here is that there were several successful initiatives that caught the board's attention. And the board has now said, has woken up. In fact, when I've talked to boards, they think they're there to help improve the health of the community. They're community members. They're not there to maximize the bottom line of the organization. Although that's how CEOs tend to manage them. They tend to manage them as, help us be good financial stewards to keep our bond ratings up. But when you really sit down with them over like a dinner, they say, well, how can we better improve the health of the community? So can you just talk a little bit more about how that story unfolded so that this became now a strategic priority of your community members that sit on the board of trustees at Cincinnati Children's?
Yeah, sure. I think, you could see how, like when Peggy Hostetter, who's the chair who just stepped down, like she remembers that housing case I shared because a New York ended up being a New York Times story. And so, she remembers the storytelling, and then became, a supporter of it. So you get your chair level support in figuring out what's the angle through your division chief, around your division chief, not around, but with the permission of your division chief, influencing, executive leadership. And I think, trying to remember, I had Lee Carter, who was the chair of the board. Somehow I got to know him very early on, and he was just one of these do the right thing kind of board members. And he personally went to the CFO along the way and ensured there was a small but steady stream of money for the legal aid work. I think I'm going to give a shout out to Uma Kodagal and Mike Farrell, who's our former chief of staff. Like, when it came time for board planning in probably 2013, 2014, saying we've got to take on work in the community, and being called on then to produce the data that says this is not a full risk endeavor. We can make progress. We can use what we've used methods wise with quality improvement, and convincing the board that of all the many community initiatives, we have some demonstrable impact and could begin to lift up strategic goals that the board could get behind. I think, I'm not an expert in board management. We have invited board members, and actually I think, Uma, Michael Fisher, Jim Anderson, who I think was our CEO at the time, and myself, we actually organized a board retreat in the community in 2014, in which we had that OB, Dr. Elizabeth, and we had a school teacher, and we had the head of Success Basics speak to the board as part of strategic planning for the following 5-year goals. So, Chris, please build on it of other ways you've successfully engaged your board over time, but trying to figure out what are those, what's your evidence? So you're not just talking, like, how do you bring your rigor and your data and your stories? And then what are those signature moments of engagement or networked engagement to get 1 or 2 on board? So, but now there's at least 3 or 4 board members we invite regularly to our learning network meetings, like when we hold our big learning sessions. And even when we don't invite them, I've had them show up. Somehow they heard about the date, because like I'm not supposed to directly email them with the dates, but then we'll have board members show up as part of it. Now, it doesn't mean, there's still that finance group that's worried about the bonds, and Rob is busy avoiding admissions. He is not a revenue generator right now. So there's still that tension, but definitely sequential engagement over time. But Chris, other things?
I just want to say, no, Don may want to add to that. I have nothing to add. Beautifully said. I think stories is the way. I'll just say quickly, stories and then data, and then following up with stories and data has been the way we've worked with the board. But I would say this is now to the scholars. One of the reasons why we've encouraged you to develop these relationships with health system mentors is that every health system is a bit different. The leverage points are different. The influencers are different. And as a junior faculty, you're not likely to know a board member, but it's important for you to start understanding the lay of the land within the organization so that you'll know who to go with as you begin to form these guiding coalitions, people who can help you with your ideas as well as reacting to the organization strategy. So although it's important to understand where the organization is going, there are people like Rob who've actually been able to help steer where the organization goes through his work and his advocacy within the organization. And you heard him talk about the various people that he interacted with, which is exactly what we would hope that you would be able to do in the future. And then Don, what are your thoughts about this? Because I think this is a really important issue.
I don't know that I've been mainly in the listening mode, so I don't want to interrupt the flow. Let the fact
good enough.
Yeah. And the fellows.
Yeah, we're running out of time anyway.
The only other thing I would add to that I think has been effective is inviting senior leaders, and through them the board, depending on, or inviting the board directly if you're allowed access, to do like a walkthrough through the clinic. Like there's getting invited to do a presentation or a research presentation. I think it's also often very effective to have a couple of them walk through your practice, and obviously you have to be ready and set up for that. But it lifts everyone around you when a chair or a board member comes and does a walkthrough, but it could be keyed off by you've invited a state representative to come learn about, your opioid addicted program or your special ICU discharge program, but finding ways where they're walking your walk, they're in your space is another way to help them then tell the story about what they've seen. And I had no idea we saw whatever 35,000 visits a year of low-income kids, and that they have these various services. So, all right, let's jump ahead then. And again, you can definitely absolutely stop me for questions. There's nothing absolutely critical here, but this is then what developed for our 2020 strategic plan, sort of 4 overarching health equity goals. Reducing infant deaths for the county, reducing avoidable admissions, and I just took off all the extra stuff, but this was reducing admissions from 2 neighborhoods by 20%, trying to develop a measure of thriving at age 5, and increasing child literacy in our Cincinnati public schools by 3rd grade. So there was that whole process I mentioned we went through, and we've been working on this now. We just finished up the 2020 plan. The key is establishing denominators to do it, but you can imagine each one in themselves is sort of like one of those big, hairy, audacious goals, like how are we going to get all kids reading, or who even has an operational definition for numerator and denominator on healthy mind and body at kindergarten. So all of these really unfathomable to me, like as a classic RCT design versus, as I learned about, learning systems. How do you set a big goal, and how do you engage a willing community with shared purpose to try to solve these problems, a la, solving Wikipedia or Travelocity or others as part of it. So here's how we set it up more formally. 4 outcomes, 4 improvement teams, and then a series of enabling cores. And I'll share these slides, so don't worry about writing it down. But I think, in the next slide or two, I just want to emphasize emphasis on taking our quality improvement stuff into the community, and then designing with families for community engagement and activation. And so, some of you may know we run a 6-month improvement course called I²S². We slowly cleansed it and turned it into a community quality improvement point course for leaders. And just in general, have a fair number of you had quality improvement as part of your background and training? I don't want to beat up on it, but yeah. So, again, translating what we learned for, say, a nurse clinical leader who's overseeing, 7 outpatient clinics to a curriculum manager who's overseeing all math and English instruction for Cincinnati Public Schools has taken some time. We partnered with Strive Partnership at the time, but we've been teaching improvement measurement and analysis, PDSA ramps, reliability, psychology of change, and so on, now to the community. So we're actually in our 6th year. We're just about to start our 6th cohort. We run it once a year. And, and the question is, who's in the course doing what? And really getting back to sort of this, who's in the system? Like if we're trying to produce those hairy, audacious goals for kids around reading and around infant mortality, who are the leading scalable institutions, and who would we want to train in them? And we've made lots of bets as we were learning who should be in and who shouldn't, who wasn't bound to be successful. But, the ones we're really focusing on at this point are the public school district, the agency that does all child welfare and public benefits, the public health department, and United Way over time as examples of at-scale kinds of folks who, boy, if we can build this ability to be a learning system with us across sectors, then we're much more likely to reach those goals. I'll just throw, this is one of my favorite projects. So this was a quality manager at the Child Welfare Agency that also does public benefits. And what this is like the public benefit question line. You can imagine for the county, right? I think they touch 60 or 70,000 people in the county. They were getting like on the order of 2,000 calls a day. And when you looked at the numbers, this is the maximum call or wait time. And again, I apologize, the font is small on the annotations, but basically from a maximum caller time of 60 minutes down to 10 to 20 minutes for 2,000 calls a day. And when I was sitting with her and saying, like, wait a second, like 2,000 calls, you just gave 40 minutes back on average, or on the max anyway. And I could show you the averages went from like 40 to 7 minutes, and the drop rate went from 40% to 8%. But this would be the kind of thing in which, boy, like if the healthcare system didn't have to, could share that burden of worrying about hunger and housing with the agencies who are doing the SNAP benefits and the Medicaid re-enrollment and the other child welfare benefits, if they're getting better and families are solving their problems and come in with that much less learned helplessness into your practice, and your social workers can be that much more focused on what they should be focused on. So this is just an example of one project in one institution, but this next one just shows we've actually trained up. These are the Cincinnati Public School. There's probably like 200 teachers who came for a one-day improvement boot camp. Emily Campbell was the director of curriculum at the time, and I was just inspired by her tweeting this out. Now, you talk about how do you build momentum. Today we choose to collectively use quality improvement to be the best at getting better, which is a quote from our old board chair, Lee Carter, who used to say Cincinnati children should be the best at getting better. Here they're doing plus deltas with the students. We taught the teachers how to sort of ask the kids on a Friday afternoon what went well this week, what didn't go well, what could we change. And this is the last one is one of the principals doing one of the courses we try to build a better flying plane, and you use QI principles. So again, just the spirit in which you realize there's, your point here, how do you, Chuck, you say like, who creates the vision? You don't have to actually create that much, and then you just start finding these flood of folks who actually want to do better with you, as part of the cavalry. But you need to find the ones who are willing to change what they do. So it's not like all of them went out and started their own PDSA ramps, but 10% of them are super jazzed up and want more. And 1% of them are going to become extraordinary leaders. And so along the way now, we were just talking about safe return to school for COVID, and I was sitting with virtually with one of the assistant superintendents, and she's got our detailed process flow maps for within school. And she's literally going like node by node, and where they're all ready to do SFMEAs, like failure mode analyses of where we could screw up. But you can then imagine that if you do that in public health and child welfare and public schools, that you're starting to get more and more momentum. Similarly, for this work, we invested a fair amount of time in person-centered design to energize this latest strategic plan, in which, up on the board, it says, how might we? So again, a lot of ethnographic work, and then together trying to think about what could solve the problems. I'll just jump to the results. Andy Beck led a great team that worked on the bed days from the two neighborhoods. So if you remember, one of the 4 goals was reducing avoidable admissions. So here you see Avondale now across all conditions for admissions in the top quartile, and then in the 3rd to 4th year now down at 105. So from 167 bed days per 1,000 kids down to 105. So successfully achieving that goal. And on the right, you actually see the work in the Cincinnati Public Schools. This is the 3rd grade proficiency rate. The lower line is for Black children, the upper line is for white children. And what you see is a net overall improvement for all, but in the process closing the percentage in the difference in rates of passing between white children and Black children from a 41 percentage point difference to a 17 percentage point difference. And again, when you go back and you think of having trained 200 or 300 school leaders and teachers in improvement and how to get better, and you have parents at the table, what might be achievable. So I'm just going to finish a little bit of like how I was doing things. So like we started with this learning system between pediatrics and our legal aid partners, thinking about housing and domestic violence and hunger, to thinking like, what would a fully networked city look like? Like what is required for kids to thrive? OB, home visiting, pediatrics, preschool, like that whole circle are all key elements in the system. And keeping it personal, right? So kids at the center. Those are 7 of our babies and moms from Avondale. And each one of these leaders, having taken our quality improvement course and or sponsored their own key operational leaders for the improvement course. So the Commissioner of Public Health, City Councilor Greg Landsman actually ran Strive and took the course. So we have a city councilor who knows improvement now and definitely thinks in a systems kind of way. and so on. And each of them having carried out their own improvement projects as part of it. And what they realize is, again, we're all working with the same families. And so in these improvement courses, they're meeting, public health is meeting education, who's meeting healthcare, who's meeting, early childhood ed, who's meeting legal aid as part of it. So this idea that my dream is that Cincinnati become the city that's the best at getting better, but we do it in a scalable way. We're learning with other cities and sharing with other cities as part of it. So I'll pause there and welcome questions. And I hope I didn't make it sound like too linear. I mean, I typically don't spend enough time on the failures along the way and the bruises, but welcome any questions or thoughts or pieces that seem missing.
I guess I'm wondering, those of us who work with kind of these specialty populations, like in my case, families of children with congenital heart disease, and I'm in Delaware, but we serve 4 states. I think what's really tricky is that there's not just, like everybody has a different insurance, everyone's in a different community, every county has a different system. And so I'm wondering, like, how would you, and this is a big question, but how would you approach it in a situation like that?
Yeah. I'd welcome anybody else to reflect as well. I think you'll notice I don't have a lot of rural work going on, right? So a version of what you're describing. So as things get more sparse, how do you solve the complexity of many places, many systems involved? I don't have any easy pat answers, so I think it is tougher. And big question is, well, what works in Cincinnati? Would it work other places or for different populations? I think in general, I would start small and solve for 5 of them, right? Solve for 1 of them, and then solve for 5 of them, and see if there's some generalizable lessons. If you did a Pareto of, imagine you have 1 kid with a congenital disease in each of 5 cities, Tom Nolan would say, identify what those 5 need, or those first 10 need, and by the time you're done really deeply understanding those 10, you've probably got 70% of what you need. And that doesn't mean you can apply all your time finding that 1 school nurse or the 1 school district leader or the 1 pharmacist, but my sense is there's room for distributed learning. So if you could find 1 school nurse in each of the 5 places, could they be part of a virtual learning system together, as one example of how to think about it? Or start to think about, how do we differently deploy our care managers or our community health workers to be more of a node in a network of knowledge, where they're picking up information from each of those 5 different cities and learning the key contacts and key intervention places. I don't know, others?
I've just had this experience with, like, even you're talking about home visitors and trying to connect families, and realizing that every state has different programs, and they're funded in different ways, and they have different criteria, and the counties are different. It's tricky when you think about these systems of care outside of our hospital, which that's like the one thing that's constant. That's the only thing that's constant. All of these kids get care at the same hospital, but that's pretty much it.
Yeah. I think learning from that variation. So, maybe given your stage, like, the key is where to focus. Like, there's so many possible places to focus, but I might Pareto out the needs and where the most efficacious things are in terms of services, and where is that variation in highly efficacious services. So, again, if it's access to pharmacy, or if it's access to home infusion, or it's access to whatever, tell that story across 10 kids and start by describing the variation, and ask the question, where are the opportunities to learn, and how do you create sort of an informal learning system, maybe. Be a thought. Welcome other answers or other questions. Welcome. Sarah might have dropped off, but Anita, Chuck, you've been working in these tough spaces around equity for a while. Things that you've pursued that didn't get touched on here, or barriers or celebrations?
No, I think just a reflection I had is I think when we're coming kind of from the junior faculty perspective, we have this vision of what the complex or what the complexities are. And so trying to navigate, like, how do you narrow down and like kind of using the traditional research methods to like focus in on one area to really kind of build your skill set in that, but then still think of the vision that you have and trying to put that together, I think is always something that I kind of go back and forth with a little bit. So more of a comment than a question, but.
No, it is really hard, right? You hear focus, 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 and yet, you know, the big things are all big and complex. So, you know, how do you create a successful niche and get your learning in? You know, again, Chris and Don and others have struggled with this as well. I think I sometimes hear Lloyd Provost, who's another one of like the QI gurus who helped us, who would say, you know, always have full scale in mind, but then start learning at the level you need to start learning at, right? So that even if you're saying, hey, in the end, I'm going to focus on whatever, exposure to domestic violence and discharge, make it up. But here's where here's the scale I want to get to and the outcomes I want to get to. And here's the piece that will be learned in the next 6 months or the next 12 months. But you're not running your study as an end in itself, but rather, you know, you're building the knowledge of the system and how to intervene as part of it. And you know, in the end, I'll say, I still get folks who don't want to see this system. I get a lot of push to say, hey, can we just take on hunger? You know, like, why do we have to do hunger? You know, it's too much. You know, and that's where, you know, again, I think don't yield where you don't have to go small and focus. Like, if you really think that contravenes what's actually going on in the lives of families, like families rarely are only concerned about hunger. And if you just had a pantry, they'd be fine, right? You know, in the end, saying I'm gonna create a learning system. I'm gonna mitigate the risks of taking on something so big. You're not funding me for a year to run this one pill. You're gonna be funding me to learn what it takes to solve what needs to be learned. And here's how we'll know whether I'm on the right track or not, or the wrong track, within a week, and then 4 weeks, and then 8 weeks. And here's the data, and it'll be, you know, I'll share that data right away. So mitigating the risks by being as transparent and humble in your build of a learning system as possible.
I was just going to share the reflection that I remember as a fellow watching a lecture by Tom Boat as he reflected on his career, starting out in like a very basic science focused scientific way, but then how that's expanded kind of the more you pay attention to your individual outcomes, how now, you know, the most important thing is really what you're talking about. Like these larger societal issues are really the drivers of a lot of these things that we individually care about. And as I've started my fledgling research career focused on a really small thing like rejection in kidney transplant patients, I've been inspired by this sort of work, and a lot by Ray Bignell, actually, who has a really great equity worldview within nephrology that, you know, we're kind of intentionally putting up blinders to not pay attention to that stuff because it feels too big or too hard, but you're not going to make meaningful progress by not including the equity. So like some of my next steps now are thinking about how do I incorporate what I'm doing, which I still think is important, but not intentionally ignoring these other things that are going to be a huge driver of these hard clinical outcomes. So, you know, creating aims around that, and how can we measure that, and how can I make it meaningful so it can potentially be fundable and somebody will let me do it, you know, at the same time as trying to solve problems. So.
Yeah, it's great. I'll just add, I'd say one of my misses over the years has been, and even in this talk, is framing this, in what way is this relevant to racism and its impact? And obviously, you know, one could have many talks on racism as a system of oppression and how do we create a learning system to get out of it. And also, I'm equally inspired by Ray, but I think, you know, how do you operate on multiple levels and bring them forward at the right time? And when I think about, and I had this conversation with Elaine Fink at Legal Aid, like, in what ways is the work we do about anti-racism or not? And when you think about that housing data, and I can map those housing dots against the redlining maps of Cincinnati in 1930, which we've dug out. You know, so So it's not that I started my career, trying to say, how will I address directly the issues of racism, but where can I start and how does it speak to some of the larger forces at work? So I have not been good about calling out when we're dealing with pharmacy deserts, food deserts, lack of home ownership, that it's a product of systemic racism over centuries. But I do think, again, constantly seeing that whole system and that system science approach and saying, how is what I'm doing today speaking to these other elements, even if I'm not taking it on directly at the moment? How do I learn to talk about it in meaningful ways? I know we're at 1:30. I am happy to take offline if you send me an email or you want to send me your project abstract and brainstorm with me for a few minutes. I'm happy to take any offline stuff, and I'll get these slides to you all.
Thank you so much, Dr. Kahn. We really appreciate you taking your time on your busy schedule and sharing about your work, and I think really inspiring and encouraging us to really think about complex and challenging issues within our own space of work. So thank you so much. Thank you, everyone.
Thank you all for listening. Thanks for the great questions. Appreciate your time.
Thank you, everyone.
Thank you, Rob. Take care.
Thank you.
Bye now.